Hello again everyone, David Wilson here from Dr. Stem Cells. This is going to probably be one of the last, if not the last video in our platelet series where we look at PRP as based on the American Academy of Orthopedic Surgeons Technical Data and Review. Now let's just jump straight to it. Today's video is going to be based on the treatment for knee osteoarthritis as looked at when we tried to discover was there significance or superiority for PRP versus bone marrow concentrate, and when we look at autologous conditioned serum. Bone marrow concentrate is retrieved or aspirated from the bone marrow, as it makes sense. That is where you have to take a long needle, you inject the needle in, you place the needle into often the iliac crest, and you remove bone marrow from that area. It can be quite a painful procedure. It's not really possible to use local anesthetic to numb the inside of the bone. So in general, patients need to be well sedated or to have local blocks, maybe spinal nerve blocks, epidurals or similar. So first of all, from a purely practical perspective, they're not really comparable. Secondly, bone marrow concentrate will contain stem cells. They will be a mixture of hematopoietic and mesenchymal stem cells. Mesenchymal stem cells are stem cell precursors to bone osteocytes, muscle myocytes, and cartilage chondrocytes. They're also the precursor for fat adipocytes. PRP, by comparison, is a blood product. The PRP is taken from a simple blood draw and contains platelets, which are concentrated up inside the patient's own plasma and given back to the patient as an injection. PRP can stimulate stem cell activation and growth. However, in general, you need to have stem cells present for that to happen. We look at this one moderate quality study, 2020, and they looked at 90 patients, PRP versus BMAC or bone marrow concentrate, and they still showed no statistically significant difference in outcome. Now, this is actually quite interesting. I've heard some colleagues refer to bone marrow aspirate as a super PRP or a PRP plus some stem cells, because with a bone marrow aspiration, you're always going to have quite a lot of blood contamination into the actual product that's concentrated up. The PRP group did, however, statistically significantly better than the bone marrow control for WOMAC. Pain, given the limitations of one single study and the lack of statistically significant outcomes, is inconclusive if PRP provides better results as bone marrow aspirate for knee osteoarthritis or vice versa. Additionally, research comparing PRP and bone marrow concentrate may yield more clarity, and that's absolutely right. We need more research into this field. Now, another thing to suggest is also, in many cases, patients are actually offered a bone marrow followed up with PRP afterwards. So there are many more cases, I think, where we'll see patients actually having received both together. And that makes it also difficult to say which is better, because in many cases they're going to have benefit from both. Now, when we've discussed a little bit of the modality, how they work, bone marrow would have certainly theoretically a greater potential for growth and repair simply because of its contents, which are stem cell. And it will also have many of the same benefits as PRP because of the blood that gets into the actual aspirate while you're withdrawing and while you're taking out from the iliac crest. On the other hand, PRP is limited to the fact that it is platelets and plasma, so it doesn't have that same potential maybe for growth unless there are stem cells present in the area already. And so we would probably suggest that tentatively, I think bone marrow will come out a little bit ahead. However, I think it's going to be less than maybe traditionally we've been saying to people. This has to be kept in mind that it's not the same as an adipose-derived mesenchymal stem cell or umbilical cord-derived mesenchymal stem cells, which are wart and jelly and the like. Those have different classifications and statistically very different in terms of the number of stem cells present in the aspirate. Finally, we want to just very briefly mention PRP versus autologous conditioned plasma. Now we're getting down, kind of scraping the bottom of the barrel in terms of the data here. One moderate study was included, and it looked at a total of 62 patients. So one study, small patient cohort. I'm not sure how much this really says, but this study showed that there were no significant differences between PRP or ACS treatments on WOMAC and IKDC, which is a knee function score, at 1 or 6 months. However, the autologous conditioned plasma did have an improved visual analog scale for pain than PRP at 6 months. 60 patients being reviewed in one study is not enough data for us to make any meaningful conclusions. My personal feeling on autologous conditioned serum is that it's virtually the same. Now, I know it's not identical, but it's very close to what PRP is, and it seems to contain a lot of the same growth factors and healing factors. So my opinion is actually that we'll find out probably over time that PRP and ACS are close enough depending on the dosage given. I want to just mention in closing then that the last thing we need to be very careful of, especially when comparing PRP and bone marrow concentrate, which is traditionally called a stem cell treatment, is cost. Your stem cell treatments are generally speaking going to be much more expensive than a PRP, and in this case, when we have now granted small number of studies, but I think it would be difficult to say to a patient that they ought to choose one over the other if the data isn't there to support it, given the huge financial difference, the huge economic difference in terms of cost to benefit ratio. More data is needed before we can say anything conclusively on this, but these are my feelings as we stand right now. So this will conclude our series now on the comparisons, the trials. There are a few paragraphs here which are maybe worth taking a quick look at just in closing. Benefits versus harms. I should probably do a video talking about that. It'll not be part of this series, it'll be a different one, but no significant harms were reported. And at the end of the day, PRP is an autologous product. It ought to be very low risk. Important priority outcomes, PN validated patient reported outcomes, quality of life measure. Cost effectiveness, we have very little data on this. Acceptability, PRP is commonly accepted as a safe biologic due to its autologous nature and the case of preparation. Yep, the ease of preparation for venipuncture, absolutely correct. I 100% agree with this. Feasibility, almost no limits to feasibility of using PRP for knee osteoarthritis in the clinic or operating room setting, as venipuncture is usually performed without any difficulty or risk. That is correct. PRP preparation is primarily performed using FDA-approved centrifuge systems and kits provided by commercial entities. Now, again, I actually have a course on teaching people to use generic equipment, but regardless, that generic equipment is of course always FDA regulated and in very common use in many practices across the country. Finally, injection of PRP into the knee joint is a routine procedure performed in the office or operating room and will not limit feasibility. That's absolutely correct. These are treatments that ought to be able to be offered by standard practitioners, general practitioners, family healthcare, family medicine. You ought to be able to get it from anyone, from your family medicine specialist right up to your orthopedic surgeon. I think more and more we're going to see PRP become a widespread option available. I know that in the UK, physiotherapists are getting very interested. There's a lot of physiotherapists who have taken their injection course and are now ready to both provide and prescribe. And I think PRP is going to be an excellent opportunity for them to offer patients low risk, hopefully high reward treatments. Anyway, this has been the end of the series. Thank you for joining me. I hope you've learned something. If you have any questions or any other topics you want us to discuss, drop us a comment down below. I read all the comments, and we'll see you again in the next one.